We're using the rectus capitis major and minor for our fine tune of the Y. And the minor comes down in the center in here, and the posterior major comes out down like this. Minor attaches to the posterior arch of the atlas, and major attaches to the C2 spinous. But our scanning is just below the skull, right in through here, where we can feel those. And it's very discerning, very, very easy to feel when the patient's laying on his back. Now this patient is out. We've already discerned that from the sitting scanning. So he can feel tenderness at C1 and C2 bilaterally, worse on the right hand side. So he knows that, we know it. We've already checked the leg length. And now I'm going to lay him down and we'll scan the suboccipitals. So lay on your back, sir. And I checked the lower cervicals just for taut and tender fibers. He has a little bit of tenderness down in the lower cervical spine. I don't use that discerning to change the y-axis. That's just more of feedback for me. Did I get it all, number one? And it's a very good objective and subjective finding. When it clears out, it's more impressive to the patient. So then I move the pillow up just a little bit and come right off of the suboccipitals, right where the suboccipital ends right there, and you can feel the rectus capitis minor and the rectus capitis major right there. And the patient can feel it as well. He can feel it right there and right there. You can see the little bit of a grimace there. So, and it's a very light touch. It's not much, about the same as the sitting scanning. On very muscular patients, you've got to go a little bit deeper than that to feel it, but it's quite easy to feel in the relaxed position in there. So we know this patient's out. We're going to adjust him, and then we'll come back in and we'll rescan all three things. We've just adjusted this patient. Now this is an old patient. We've adjusted this patient off of his old listings, and we've scanned him. He scans completely clear. There's nothing at C1, there's nothing at C2, nothing at C1 or C2 bilaterally. I've checked his leg length already, and his leg length is even. So normally with the current protocol, we would not adjust this patient. However, when we lay him down, lay on your back for me, sir. When we lay him down in the supine position, and I come in and I touch the rectus capitis major and minor, he can tell you that there is still tenderness there at the rectus capitis minor. There is not tenderness in the major. Is that correct, sir?
Correct.
Just a tiny bit right there.
Yeah, just
okay.
Less than one.
Less than a one. And on the right hand side, it's worse bilaterally, and it's worse on the right hand side. So this is a perfect example of what the supine scanning gives me versus the sitting scanning, because that's already all cleared out and we would have left it alone. So what we're going to do with this is change the y-axis. He is a typical high, so I'm going to reduce the y-axis, just same rules of the atlas orthogonal rules. On a typical high, we would reduce it more towards 0, and we're going to come back and adjust it and recheck it after that. Now, palpating him, he still has quite a little bit of the taut and tender fibers in there, which tells me I need to change this several degrees. And just like the sitting scanning, we can, after you do this a while, you can kind of figure out, okay, do I want to swing this Y 5 degrees? Do I want to swing it 1 degree? Based on that information, feedback of palpation. This is the same way. His felt like that there was quite a little bit of tension still in there. I'm actually going to change him 3 degrees, and then we'll recheck that. But that's more of a learned thing over time that I've kind of developed using this for the last 10 years. I've just readjusted this patient. His sitting scanning is still clear. We've checked his leg length already, and it is still even. And so now we're going to check the supine scanning. So lay on your back for me, sir, if you would. Now, the rectus capitis on the left, rectus capitis posterior Minor is almost completely clear, but it's probably 75% better. Is that a rough guesstimate right there?
Yeah, more like 90.
90%. This one is probably about 90% better as well. Is that correct? And on this side, we are probably 50% better. Is that correct? Okay. So again, the patient can feel that improvement just like the sitting scanning. This tells me we haven't taken him far enough, and we're on the right track, but we haven't taken him far enough to get the ideal y-axis. So now we're going to come back in and readjust this patient. We never adjust over three times in the same visit, just like our old rules, but we are going to adjust this the second time now. This patient just communicated with me off camera that they didn't feel as much pain. All it felt to them was a tight muscle, and I would agree with that. That's what we're feeling is taut and tender fibers. However, if we just do the old eyeball pressure scanning, it feels like a taut and tender fiber to the, or just tightness to the patient. However, with just a little bit more pressure, the patient can communicate, you can see a little grimace there, the patient can communicate that there is pain there. So we take it, we can take it to the next level or not. I've done it both ways depending on feedback from the patient. But it is definitely a palpable muscle, and we can tell it's improved from before, but we can also tell that there's still some taut and tender fibers there, because when we have the y-axis correct, there will be no pain. It doesn't matter how hard we push on it, and there will be no taut and tender fibers there at the rectus caps. We've just readjusted this patient again. I've checked the leg length. The leg length is actually now, the short leg is about 1/16 of an inch long. So we know we've made improvement from that, because before it was just even. We've done the sitting scanning. The sitting scanning was cleared out prior to these last two adjustments. Now we're going to check our fine tuning of the rectus cap. And as we come down through here again, I'm going to feel that rectus cap on the left, and I do not feel any taut and tender fibers to the patient. Do you feel any taut and tender fibers?
No.
Right there. And rectus cap major out here, same thing. On the right hand side, now with him, the right hand side was more than the left. I can rub that now and there's no pain. Now in this case, when prior to this, I had not pressed hard enough, and I'm going to actually lift up a little bit on the occiput. I can pull that clear off the table. I can pull the whole head clear off the table and rub that, and the patient can give feedback. There's no pain there when I do that. Is that correct?
Thanks.
Okay, I don't feel anything. I have never had the atlas go out when I've done that. Been doing this for 10 or 15 years, and that has never displaced the atlas, so I don't have any fear of that. So what this has allowed us to do is, now let me back up just a little bit. We had swung the y-axis 3 degrees. It was about 75 to 90% better. I only changed it 1 degree, and we were able to get a complete clear out of that. So this has allowed me to fine-tune the atlas y-axis rotation, and I expect the adjustment to hold much longer because of that fine-tuning. The patient just communicated with me off camera that they didn't feel like that I was pushing as hard the second time. And that's a lot of why sometimes I'll lift the whole head up, and we've never ever had an atlas go out doing that. But when I'm scanning that, it hurts, and when I'm touching it, when their atlas is out, they feel it hurts quite a little bit. And so that's why a lot of times I will actually put my scanning fingers there and lift the whole head up, clear off the table, and rub back and forth so they can feel that subjective change from my objective change. So it's very, very frequent that they don't feel like that I'm touching as hard, and that's why I started lifting the whole head up to prove that to them, because it just doesn't hurt at all when I clear it completely out, and a lot of times the patients have a tough time understanding that it's gone. This technique, the supine scanning, is used exactly like the sitting scanning, the same set of rules, everything. I feel like that the supine scanning is much more discerning for fine-tuning the Y, as we demonstrated in our example, that the sitting scanning had cleared and we still had the taut and tender fibers of the rectus cap major and minor. But we use exactly the same rules. We're just going to use typicals for right now. So if we have a typical high and we come out with a Y4, we would change that and obviously decrease the Y in this case first. That would be our rule. And again, based on the amount of taut and tender fibers in there, it's a little bit of a learned thing over time, but the amount of that would tell us, do we only change it by 1 degree to a 3, or do we go all the way down, say 3 degrees all the way down to an anterior 1? So, I'm sorry, this should read anterior right here. So the same thing, and with the posterior, atypical low, is we have a posterior rotation, reads out on our vectors of a posterior 5. In this particular case, we would always increase the Y, again following the old school. It doesn't matter if it's a category 4, it doesn't matter if it's an atypical. Those same rules apply from the sitting scanning. It's just one more tool to make a more fine-tuned and discerning Y-axis correction.